don't want to talk to anyone else. I need to put an IV in one, and I need to talk about discharge plans with another. Can you help me out?
Sure.
Patient in room 23, Bob Smith. He needs penicillin intravenously.
Okay.
I'm going to delegate you this task. Is that okay?
Yeah.
Here's his chart.
Good afternoon, Mr. Smith. How are you doing today? I'm Alessia, licensed practitioner nurse. Good. I'm going to give you IV. Your doctor will prescribe it if it's fine with you. Okay? Okay. Is it okay for you? Okay. I'm going to check in a couple minutes. How are you, Mr. Smith? Mr. Smith? Mr. Smith? Call me code.
On April 28th, 2011, I pronounced Mr. Bob Smith to be deceased at 12:30 in the afternoon. Hello, I'm Dr. Gomez. I am the doctor on duty. I was actually just brought up to speed with the incident that happened in room 23 with Mr. Smith dying from an allergic reaction to penicillin. I understand you were the nurse in charge, and you delegated the duty to administer medication to Mr. Smith to the LPN named Alessia, correct? That's correct. As you might be aware, we might be facing a malpractice lawsuit, so we have the story straight. Before we get started, I want to ask you, are you aware of my rights of delegation?
I am. The right task, which it was. This was the right circumstance. I delegated to the right person. I have the right direction, and I had proper communication.
Okay, well, that's good that you had the right direction and proper communication, but unfortunately, you are missing a very important key, which is supervision. Your responsibility was to actually go back to the patient, evaluate the patient, and see signs and symptoms, and perhaps you would have caught the fact that he was having an allergic reaction, and this whole thing could have been prevented. Hi, Alessia. I am Dr. Gomez. I understand you are the LPN in charge of providing penicillin to the patient. Okay. I just want to ask you a few questions. How often did you actually check blood pressure readings of the patient, and did you also check the intake and outtake fluids of the patient?
You know, doctor, everything happened so fast, and the patient went into shock right away. I didn't have time to just died right away. I checked him a couple minutes, and selected the
Okay, well, I understand it's a very stressful situation for you and the nurse. And I just want you to know that, the hospital's backing you up on this. Unfortunately, things like this happen every day. So I just want you to know that, it's going to be okay in the end, okay?
Alessia, what's going to happen to me? This patient dying is all my fault. I should have been supervising. I should have watched. What am I going to do? What's going to happen to me?
And we're going to get on that. We mail it.
we in hospital, patient died,
And there's
nobody could ever say what
I
happened.
know, I think we're going to the high risk environment.
Well, I want you to kind of think about that video. Obviously, that's somewhat of an exaggeration of what could happen, but it could actually happen where when one of those components of delegation are not completely implemented, you can see where a serious situation could happen. Obviously, she left off supervision, and I think, too, she really didn't communicate what should be done when this person was to receive this medication, especially being the first time that the patient was receiving the penicillin. She should have gave very, very specific instructions to that LPN that she should stay with the patient for the first few minutes and check vital signs every 5 minutes. and assess the patient's respiratory status and cardiac status. So I'm not sure if all of them was completely fulfilled besides the supervision. I don't think she communicated exactly what she wanted that nurse to be doing. But anyways, I wanted to share that with you and really show you that if we're going to do and implement delegation properly, then we need to make sure that all the components of delegation are included. Okay, what I have up here on the screen is an activity that we can do together. It's, again, related to the exemplar of delegation, and here is the case study. You are working the night shift on a medical unit and have been assigned charge nurse responsibilities. You are working with 4 RNs, 1 LPN, and 2 UAPs. A client becomes pulseless and is not breathing, and the nurse assigned to the client's care calls a code. The nurse is occupied at this client's bedside for 1.5 hours until the resuscitation effort is completed and the patient is transferred to the intensive care unit. This nurse also has 4 other assigned clients. In addition to the nurse assigned to the care for the client requiring resuscitation, 2 of the other nurses working on your unit are assisting in the code. So our first question is, what tasks could you delegate to the UAP? And hopefully you're able to answer this with after viewing the Pearson video on delegation and the PowerPoint that I presented to you, which are uploaded in your Canvas course as well. As a charge nurse, you could delegate to the UPAAs tasks that do not require nursing knowledge and skills. For example, you could make sure that the UAP is going around and making sure all the patients are safe that are in your care, because you're tied up in that room with the patient who is coded. You might want to delegate vital signs, and of course make sure all the patients are safe. I would also suggest that you delegate tasks that the UAP had performed competently before and was comfortable with, and I would only delegate care for stable patients. So if there was another one of your patients that was a little bit iffy on their condition when you did your last assessment, I would not have that UAP go in there and assess that patient. You would delegate that to another RN because they could not make that assessment or give you an update on that assessment of that patient, and that would definitely be out of their scope of practice. Question 2, how will you maintain the safety of the other clients on your unit while 3 nurses are occupied with the client requiring resuscitation? This is where you may want to implement a type of functional nursing care for the duration of the code and instruct the team to focus on the most critical tasks that need to be completed. Observing all the patients, administering of medications, and completion of treatments would be the top priorities in this situation. And it would be advisable to temporarily reassign the clients of the code participants to other team members. So you can adjust the assignment sheet until this patient either is transferred or has stabilized, and the nurse who is been assigned to this code patient can go back and resume her responsibilities to her previous assignment. All right, question 3, how might effective delegation to other team members contribute to the care of the clients on the unit? And I think that's a great question, so I want you to kind of think about that as well. Effective delegation would ensure that all clients are provided an appropriate level of care by an appropriate team member. The nursing staff available to assist with client care has been reduced by the code. Therefore, it would be necessary to ensure that the remaining RN and LPN complete only those tasks that require their skills. All the tasks that can be performed by UAPs would be assigned to them. So use those team members appropriately. And above these questions in this case study scenario, you see things that the RN can do, the LPN can do, and the UAP can do. So just wanted to go through that activity with you that pertain to the 5 rights of delegation. Okay? All right, so we're going to now do the practice question and answers pertaining to delegation. All right, let's begin with question 1. In regards to our exemplar of delegation, the new nurse is interviewing for a position on a med-surg unit. The nurse asks the manager what opportunities the nurse will have to develop, skills, especially delegation. The manager tells the nurse that promoting delegation is a goal for the unit because RNs are too valuable to do bed baths, client satisfaction increases, there is not enough qualified staff, or productivity is too high. And this seems a rather obvious answer is number 2, client satisfaction increases. And I would be very upset if any of you chose number 1. Good job, good job. And here is the rationale behind that. Through delegation, client care becomes more efficient and client satisfaction rises. RNs are not too valuable to do all care, but with a shortage of RNs in the country, delegation to others help the RNs with care delivery. Staff members to whom actions can be delegated need little training and are not necessarily in short supply. Productivity increases with delegation and cannot be too high. Good job, everyone. All right. Question 2. An RN has been assigned to care for several clients on the shift. An admission experiencing pneumonia is to arrive from the emergency department. The nurse plans to delegate which of the following to the LPN or LVN regarding this client? Good question. Administering IV push morphine for pain, performing admission assessment, taking the telephone orders for morphine from the physician, or performing a focused assessment. The answer to this for the LPN is to perform a focused assessment. And let's go over the rationale for that answer. A focused assessment is performed in an ongoing manner during the shift or may involve focusing on a system such as a respiratory assessment, which the LPN, LVN can do. Only the RN administers IV push medications. The admission assessment cannot be delegated. Telephone orders are usually discouraged, but in this case the RN would take the order and the LPN or the LVN could witness the order. So that's the rationale behind that. Okay. Question 3. A graduate nurse is caring for clients and does not want to delegate tasks to the LPN or LVN because the nurse feels that the responsibility for care belongs to the RN. As a result, the new nurse may experience increased client satisfaction, lose the trust of coworkers, gain confidence that tasks will be done, or feel pride when the clients are cared for appropriately. And we did talk about this in our delegation videos and PowerPoints. And obviously the answer to that is losing trust of coworkers. All right. Question 4. An unlicensed assistive personnel has previously performed client transfers bed to chair safely on many occasions. It would be inappropriate to delegate this unsupervised task to the UAP under which of the following conditions? This is a great question. And our choices are: the unit has a new wheelchair, the client is older, it is the client's first time out of bed after surgery, or the UAP has just returned from an extended leave of absence. So I want you to think about this, which one of these would be the best choice. And the answer is, it is the client's first time out of bed after surgery. And I did talk about this previously, that when it is the patient's first time out of bed after surgery, it might be a good idea, or it is a good idea for the safety and benefit of the patient, that the RN is there to kind of assess how the patient does, to see if the patient would develop any, dizziness, orthostatic hypotension, What I used to do is, instead of getting the patient immediately out of bed, I would let them sit on the side of the bed and dangle first and see how the patient does in an upright position, and then slowly let the patient rise. So that's kind of how I would carry out the patient getting up for the first time, especially after surgery. And it would also depend on what type of surgery and how long the patient has been in bed, and obviously the age and the health condition of the patient as well. And the rationale behind that is the nurse is accountable for evaluating the client's response to care, which the UAP is not trained to do. The nurse may have the UAP assist the nurse, but for the first transfer after surgery is performed by the nurse. A new wheelchair does not matter. The criterion is the patient. An older patient is not a reason to keep the UAP from completing a transfer. Transferring clients is not a skill that a UAP might lose because of a leave of absence. So I hope that helps as we give you these practice questions, which get you much better at determining what's the best answer when it comes to an NCLEX style question. So I hope this has given you a pretty good explanation and review of exactly what delegation is all about. You may want to go back and review some of these videos. Like I said, every one of them that I have showed you is uploaded in your Canvas course if you want to go back and take notes, or just see how it correlates with your assigned reading as well. But please, I want you to understand this exemplar because it is very, very important. And even as a student nurse, when you get into the acute care setting, you may have to practice delegation, and it's okay. It's a great place to start, and you may have to ask for help. And remember, the reason behind that is it will benefit the unit itself as well as for the patient. So let me know if you have any questions about that, and make sure you've gone over your assigned reading, because it will kind of reinforce a lot of the material that we went over, especially with delegation and, of course, with the nursing process. All right, we're going to continue this lecture with our concept of communication. Okay, our concept of communication involves two exemplars. One is interpersonal communication. And I want to talk a little bit about this important exemplar, about interpersonal communication, and then also discussing therapeutic communication as well. Think to yourself, what is therapeutic communication? It really is an interactive process between the nurse and the patient. It really starts to develop that caring relationship based on mutual trust and respect, on sensitivity, on nurturing, and it helps patient overcome some of the temporary stress that they're facing while they're patients in the hospital. It teaches them how to get along with others and to hopefully adjust to their situation that unfortunately can't always be changed. It helps the patient achieve health goals and responds not only to words but also to feelings and also to those nonverbal clues. With the therapeutic communication, it is about active listening, taking the time to answer questions, and understanding things both ways, okay, from the nurse's point of view to the patient's point of view. When we talk about non-therapeutic communication, we might see things where we don't see that really caring relationship begin to develop, where you might see the nurse asking irrelevant questions, sharing unnecessary personal information, and showing disapproval for some of the decisions that you might make about your health or about the patient's health. It's always important when we communicate with our patients to become an active listener. Be aware of your own biases between you and the patient, and to be physically attending when you're at the bedside and when you are talking with your patient. When we talk about interpersonal communication, that's on individual thoughts that are kind of a form of a communication, and we might also refer this to interpersonal communication as self-talk. It describes the thoughts or the communication that individuals keep to themselves. All right, we all do this. All right, and when any two individuals are talking with one another, each of them will usually be engaging in interpersonal communications at the same time. They're thinking their own thoughts before, during, and after, and sending that message to each other. This interpersonal communication occurs constantly and can interfere with an individual's ability to hear a message as the sender intended. So a lot of times, some of us have more interpersonal communication than we probably should, because as we're thinking about our own thoughts to the present situation, we may not be an active listener, okay? Clear communication is essential to both the safety of the patient and the ability of the nurse to collaborate with an increasingly diverse healthcare team, okay? So just wanted to kind of touch upon those as well. I want you to think about the word empathy. What is empathy? And think about empathy versus sympathy. Empathy focuses on a patient's feelings and not the nurse's. It kind of lets the nurse put themselves in the patient's situation. And there are 4 phases of therapeutic empathizing, and the first one is identification. The second one is incorporation, where we consider the patient's feelings rather than your own. Reverberation, a continuing effect, and of course detachment from the situation. As an effective communicator with our patient, we are mindful and we are attentive listeners. We use all our senses when we're at the bedside and we're listening to our patients. There are many effective ways in which we can communicate with our patients. Sometimes the best way to communicate is just using silence, not saying anything, reflecting, paraphrasing, checking perceptions, questioning, structuring, pinpointing, linking, giving feedback, confronting, summarizing, and processing. Some of the common mistakes that we might accidentally or on purpose make is giving advice. We as nurses should not give our patients advice, and many times our patients will respect us so much and think so much of us, they might ask us, hey, what would you do if you were in my situation? And that is the time when we would say, I really can't tell you what to do. That is a decision that you and your family need to make. Another thing we should not do is minimize their feelings, because they're important to that patient, and we shouldn't say, oh, you shouldn't feel that way. That's really not that important. Deflecting, interrogating, or disagreeing with your patient, okay? There are some barriers to communication as well. Failing to listen, improperly decoding the message, and placing the feelings of the nurse before the patient. That therapeutic relationship that is developed between patient and nurse. In a therapeutic relationship, it helps patients manage their problems, helps patients become better at helping themselves in their everyday life. So these are just some points I wanted to bring up in regards to communication, which is a very important aspect in regards to how we develop a trusting and respectful relationship with our patients. Okay. the second exemplar that has to do with communication is Introduction to Charting. And I do have on the screen here Appendix 6, which is a little bit of a case study here that talks about point of care charting. And documentation and charting is a form of communication, so that's why we're talking about this right now. So let's look at this case study with Zaina Catton, our 23-year-old nurse from a small rural community. She graduated from nursing school a few months ago and took a job working on a general med-surg inpatient unit at a neighborhood hospital. Her goal is to eventually work in an adult intensive care unit. She recently received a sign-on bonus and looks forward to buying her first new car. Zaina has a busy week because of increased client loads. She has 7 to 8 clients of her own, and she has trouble managing her charting with all the client care she has to do. She ends up staying up to 2 hours after each shift to get the charting done, and Zaina's manager, Pat, talks with her about this and reviews the importance of point-of-care charting. The feedback he gives Zaina is generally positive. So let's look at these questions so that we can kind of determine what could be Zaina's problem and what could we do to help her with this constant overtime that continues to occur. Because I'll be honest with you, hospitals don't like to be paying out extra money and have nurses stay just to do their charting. So why is Zaina's manager trying to improve her point of care charting? The manager is emphasizing point of care charting so that services are charted as soon as they are performed. This will eliminate the 2 hours of overtime, and information will be available immediately and not forgotten. And what we mean by point of care charting is that it's done as soon as the task or skill or assessment is done with the patient. Because if you wait later on in the shift, we will see that the documentation is not as point on, and if someone was going back to kind of look at the events that happen in that patient's day at the hospital, it might not be that specific and not as accurate as we would like it to be. So that's why it's important that we as nurses do point of care charting. Chart after the situation has, you've experienced it, and that you can get it documented when it's fresh in your mind, and you can give all the specific details and be as accurate as you possibly can. We're supposed to chart our medications as soon as we give them. It's important that we do the documentation as well. Question 2, what are the potential drawbacks of waiting until the end of the shift to document care? Obviously, we forget a lot, especially now that nurses are working 12-hour shift. If something happened at 11 in the morning, it's very hard to think about, oh my gosh, at 5 o'clock later on, which could happen, 7 hours later. What happened? Let me think about what I did with that patient when his blood pressure dropped. Now, what did I do? What did I do first? When did I call the doctor? Let me think about what medication I gave that patient, or whatever the case may be. So that's the drawbacks. And also, it gives you an opportunity to notice that something that should have been done wasn't. So it's important to know that, oh my God, that's right, at 10 o'clock I was supposed to get some labs drawn. If you think about that at 5 o'clock, that's 7 hours later, and that could be a very, very serious error or negligence of something that should have been done for your patient earlier in the shift. So question 3, what strategies might you suggest to Zaina to help her improve point of care charting during a busy shift? Zaina should first prioritize her work at the beginning of the shift. She should also find out on rounds which client needs pain medications or anything else that needs immediate attention. So this should be her first priority so that these clients will be taken care of for a time. And if an emergency comes up that puts her behind, she will need to ask for help. There is always someone who is not as busy. And that's very true, because when you are not doing your documentation as it happens, and then one of those patients decides to kind of tank or develop some problems, boy, that's really hard to catch up with all that charting. And you can see that her load is quite heavy. She has 7 to 8 patients. So to go back and remember, okay, let me think about what I did with Mr. Jones. What did I do with Miss Smith? All that is very hard to recall that, especially when you've been working so hard all day. And the longer you work, the more fatigued you get, and you have a tendency to forget about things. So that's what we mean by introduction to point of care charting. So hopefully that helps a little bit to kind of give you an example of what we mean by that. And documentation is very important. And I know as a nurse personally, I always like to come on and read usually the last 48 hours of what went on with that patient. And, when it's done in a specific way, it gives me that true picture of what's been going on with that patient before I've been assigned to that patient. So I like people who really document quite efficiently. And, it's very sad when you read documentation that really doesn't tell you much about what went on with that patient. And you may have done a lot of things with your patient that day and provided a lot of nursing interventions and things like that. And if you don't document that, even though you know personally you did it, it looks like it was never done. So that's why it's important to keep up with especially vital signs, knowing what AccuChecks are, reassessing patients after pain medications are given, keeping track of someone's intake and output. All that is really necessary for point of care charting, so that if the docs come in, it's all there up until what happened at the time when the docs are making rounds. He knows exactly what's been going on since maybe you came on at 7 in the morning, and if he comes in at 11 o'clock to make rounds and you've been doing and keeping up with your point of care charting, the physician will get a good idea of what's happened in those last 4 hours with the patient and what kind of care has been provided. So another good reason to do that. Plus, as with question 3 here, it really keeps you more organized with your care. And I know she's just a new grad, and sometimes it takes a while to learn that organization because you've transitioned from nursing school to now you're an RN and you're now in charge of the kind of care and the plan of care that you're going to provide for your patients. So there isn't an instructor telling you what to do. You've got to now start developing your own system as to how you're going to stay organized and being sure that everything is done for your patient. And this kind of coincides with delegation too. In order to keep on task, this is where good delegation needs to be implemented as well, so that all that needs to be done for that patient is being done, and it's being done at the appropriate times. If the person was supposed to walk in the morning and we're not doing that for the patient until 3 in the afternoon, there's a problem, okay? And sometimes it can be due to the fact that the nurse is overwhelmed. I mean, look at her. She has 7 to 8 clients. Now, we don't know the acuity of those patients, but it's still a lot of responsibility for especially a new grad, okay? So, this concludes my lecture, and I hope you got a lot out of this. And like I said, if there's any questions after you've reviewed this lecture and listened to this lecture, I'd be more than happy to help you with anything that isn't quite clear. Take care, and you'll be hearing from me soon.